Welcome to the third session in the Data for Health, Data for COVID-19 series hosted by Bloomberg Philanthropies. My name is Carlos Roig and I'll be moderating these sessions. Last week, we were so pleased to have more than 230 participants from more than 25 countries. This week, there are more than 280 participants registered from 55 countries. This session is being brought to you by Bloomberg Philanthropies, an organization founded by Mike Bloomberg that uses data to ensure better, longer lives for the greatest number of people. As you know, the goal of the Data for Health initiative is to partner with countries to improve their public health data. The COVID-19 pandemic has reached nearly every country in the world, and during this crisis, high-quality data is more important than ever. This series aims to provide technical assistance to support your ongoing COVID-19 work. Before I hand this over to our presenters, I wanted to go over a few pieces of information to help you navigate the platform. This webinar will be conducted in English with simultaneous translation to French and Spanish. You can switch languages via the translation button. Time is allotted for moderated discussion at the end of the webinar. Finally, you will notice a chat button at the bottom of your screen if you're using a computer and at the top of the screen if you're using a phone. Please direct your chat to everyone, which is the default setting. Please use this feature at any time to type questions you have about the presentation or anything related to this series. International Data for Health partners will answer as many of these questions as possible at the end. Before turning it over to our presenters, we'd like you to answer a short poll question about which language you are using to listen to the webinar. We would greatly appreciate it if all of you could answer the poll, as this will help us plan for future webinars. The poll will be up for 15 seconds. This session will be focused on verbal autopsy in the context of COVID-19. To kick off today, I'd like to turn it over to Robert Umswia, Senior Technical Advisor in the CRVS Improvement Program at Vital Strategies. Robert, over to you.
Thank you, Carlos, for the introduction. We have few speakers today. They will be introduced at a time when they are called upon to present their segments. I will begin by introducing what verbal autopsy is and how it has been applied in various settings. Then, we will focus on some technical and implementation considerations on the use of verbal autopsy in the context of COVID-19. We will also share with you 2 case studies on how verbal autopsy is being implemented to determine COVID-19 related deaths. We acknowledge that there are a couple of different approaches and tools for verbal autopsy implementation, and countries may choose one over the other. However, for this webinar, we are focusing mainly on the general principles of verbal autopsy application and how they can be improved and be of use to distinguish and determine COVID-19 related deaths. Next. Verbal autopsy is a method of estimating cause of death pattern using information obtained from caretakers of a deceased person, whereby trained interviewers visit the relatives of the deceased to conduct verbal autopsy interviews using either electronic data capture instruments or paper questionnaires. Information obtained during the VA interviews include the circumstances, signs, and symptoms during the terminal stage to find out the likely cause of death. In addition, information on healthcare seeking in the period leading to death and history of events leading to death as narrated by the respondent. Cause of death determination from verbal autopsy can be done using physician's review or using computer algorithms. Most frequently used algorithms include InterVA, SmartVA, and in silico. Routine verbal autopsy is being applied in several countries supported by Bloomberg Philanthropies Data for Health initiative. Next. In many low and middle income countries, the routine systems such as the civil registration and vital statistics are incomplete, especially in terms of death registration, and worse in terms of cause of death data. reliance on routine cause of death information has been from health facility data. However, as the data from Zambia on this graph indicates, large proportion of deaths in such countries occur outside health facilities and are therefore likely to be missed if there is no strong notification and registration system in place, and if there are no mechanisms to determine cause of death. In some of these countries, this proportion is as high as 70%. In such situations, application of verbal autopsy is the only practical alternative to the medical certification of cause of death by a trained physician and a subsequent coding of the death certificate by a trained coder. Next. There are a few instruments that have been in use. The WHO verbal autopsy tools and the PHMRC short VA forms are the current main tools routinely being applied in a number of countries that are implementing verbal autopsy as part of the CRVS and health information system strengthening for cause of death determination for deaths that occur outside health facilities and without medical certification of cause of death. With this brief introduction of verbal autopsy, I will now hand over to Erin Nichols from CDC's National Center for Health Statistics and a member of the WHO Verbal Autopsy Reference Group, who will present on considerations for use of verbal autopsy for COVID-19 epidemic awareness. Over to you, Erin.
Thank you, Robert. Good day, everyone. Next slide, please. I'll be sharing today emerging guidance and considerations for using VA in the identification of COVID-19 deaths. It's important to note that it will take time to conduct the research and testing necessary to appropriately update the existing methods. So I'll therefore discuss how COVID-19 deaths are likely to appear in currently available VA tools, key areas of further development for COVID-19, and options for adapting COVID-19 specific tools. Next slide. I want to mention a few key caveats that are always important to consider when using VA. First, VA, as described by standard WHO guidance, is well accepted for measuring population level mortality. However, as generally practiced, VA is not suitable for assigning a cause of death for individuals for legal purposes. Second, the appropriate methods for VA depend on the goals and the resources available. Therefore, selection of the appropriate methods requires an understanding of the purpose and limitations of the various methods. And finally, resource requirements differ for enumerating all-cause mortality versus cause-specific mortality. So where resources may be limited, especially in the face of an epidemic, there's great value in death counts, even in the absence of cause of death information. Next slide. Though the evidence continues to evolve with recently updated WHO and CDC case definitions, several studies have documented symptom patterns of COVID-19 patients. A meta-analysis of China cases shown in Table A and a study comparing adult and pediatric symptoms in the United States shown in Table B showed a core pattern of 5 common symptoms of COVID-19 infection, including fever, cough, shortness of breath, myalgias or fatigue, and headache. Next slide. Of the 5 most common symptoms of COVID-19 infection, the 2016 WHO questionnaire is able to capture fever, cough, breathing issues, and headache. There are no questions that address fatigue or muscle aching. Next slide. The WHO VA reference group is reviewing the addition of questions to specifically identify COVID-19 deaths. Of course, evidence of symptom experience, particularly among deceased patients, as opposed to all patients, is rapidly evolving, as Fatima will demonstrate in a bit with her work in Brazil. As I've already noted, the addition of questions to a standard VA questionnaire requires extensive research and testing, and my colleague Riley will discuss this further in the next presentation. In the meantime, interim guidance is being developed for VA teams to move forward with some COVID-19 specific items while we compile and review evidence for a future revision. Next slide. Where full VA is unlikely to be deployed, a rapid screening questionnaire may be collected as part of the initial death report to distinguish external other natural, and suspected COVID-19 deaths. The rapid mortality surveillance guidance that was presented during the first webinar includes guidance for a set of about 10 questions for this purpose. Such a questionnaire will soon be used in Colombia, where health officials will be sent to verify deaths in the community and ask this simple set of questions together with the death report. Guidance will also be provided for the interpretation of the short set of questions as a crude assessment of COVID-19 status. Next slide. For teams wanting to identify COVID-19 deaths from VA data for use beyond the basic rapid mortality surveillance purposes, Physician Certified VA, or PCVA, is the recommended method of assigning cause of death at this time. Guidance has been developed drawing on the items listed here. Until the COVID-19 specific questions are added in the WHO questionnaire, key additional COVID-19 items could be captured in the narrative. And as mentioned before, in general, it's recommended that cause of death assigned from VA only be used for statistical purposes, though some exceptions may be considered where testing is available. Such decisions need to be made with consideration to the context of the full system. Next slide. For automated algorithms for assigning cause of death, I'll discuss some of the considerations for the InterVA software, which also apply to in silico VA, and my colleague Riley will discuss more details as they relate to SmartVA. As the VA tools are currently, depending on what symptoms are reported, generally speaking, we can expect COVID-19 deaths to increase the mortality fractions for acute respiratory infections, including pneumonia, and possibly other and unspecified infectious disease cause categories. It should be noted that the key COVID-19 symptoms are also seen in other causes, like pulmonary TB. COVID-19 deaths may be seen in other cause categories depending on what other symptoms are reported, and this includes symptoms for underlying conditions such as heart disease or HIV. As noted before, until the VA tools are updated to include COVID-19 specifically, PCVA remains the recommended method for identifying COVID-19 deaths from VA. Also to note, InterVA 5 has incorporated an approach for assigning relevant circumstances of mortality categories, or COMCATs. And these can provide context on the fundamental drivers and influences surrounding death. These may support planning and evaluating health services to help reduce avoidable mortality. So when the WHO tools are updated to include COVID-19, the probability matrix for InterVA will also be updated. Goals would be to assign to COVID-19 where appropriate, while minimizing the impact to other existing cause assignments where no COVID-specific items are involved. However, to reiterate, this process will require further evidence, testing, and validation, and Riley will describe the revision process in more detail with reference to updates to SmartVA Analyze. Next slide. Here are some considerations for using VA for COVID-19 epidemic awareness. First, it's critical to be clear on the information goals for which you're considering VA, along with the resources available. The appropriate questionnaire and cause of death interpretation methods vary depending on if you're aiming to rapidly detect deaths possibly associated with COVID-19, perhaps as part of rapid mortality surveillance, versus if you're seeking to maintain routine, standard VA practices for cause-specific estimates. Teams using current VA tools can monitor excess deaths across specific causes of interest, and in next week's sessions, we'll provide more information on this topic. As I mentioned previously, the circumstances of mortality categories from InterVA 5 are also available to enhance the information available from routine VA. Additional guidance will continue to be compiled and shared as we increase the experience base for tracking mortality and cause of death for COVID-19 in resource settings. But in the face of an epidemic, it's important to remember that if resources are limited, efforts to track all deaths, even in the absence of cause of death, can provide critical information for decision-making. Next slide. I'll wrap up here with a few considerations on VA implementation. First and foremost, appropriate infection prevention and control measures should be followed, and guidance for such measures is included in the forthcoming Rapid Mortality Surveillance Guide. We can anticipate that accessibility to VA respondents will decrease, and activities of routine community workers, who are often key VA staff, may be disrupted. Where VA has been routinely conducted, death tracking should continue, though the VA itself could be conducted at a later time. Mobile communication can offer solutions to maintaining safe distance during data collection. This has been demonstrated in Morocco, where Municipal Health Bureau workers contact families by phone to conduct a VA after the death in the community has been reported. Also, new burial processes where the government may intervene to bury those who have died in the community, as is happening in Colombia, can offer an opportunity for brief contact with the family to collect basic information on the death and possible cause of death. In short, despite the many challenges that COVID-19 will pose, there will likely be opportunities to innovate and reimagine solutions to ongoing challenges in improving mortality information. The VA community is well positioned to compile these lessons learned and to reshape practices moving forward. Next slide. I conclude here with a link to the implementation website for the WHO VA reference group, where we'll be posting our guidance. Subscribe to the mailing list to receive updates. And now Riley Hazard with the Global Burden of Disease Group at the University of Melbourne will provide more details on the VA modification process for SmartVA. Next slide, and over to you, Riley.
Thanks, Erin. I'm going to talk about the use of SmartVA in the context of COVID-19. Next slide, please. I'd first like to talk about some additional considerations for adding symptoms to a VA questionnaire. In order for a VA symptom to be endorsed on a questionnaire, the symptom must first be recognized by the respondent or communicated to the respondent by the person who died. Next, the symptom must be remembered by the respondent. Sometimes VAs are conducted up to a year after a death. Finally, a VA symptom must actually be endorsed by the respondent. There are a number of reasons why a symptom might not be endorsed on a VA questionnaire. A respondent may not recognize a particular symptom. They may not remember the symptom, or they may not endorse the symptom for reasons such as stigma. I'd like to emphasize here that symptoms that are clinically associated with COVID-19 may not ultimately be reported on a VA questionnaire for some of the reasons I've outlined. Next slide, please. Next, I'd like to talk about adding COVID-19 as a potential SmartVA cause group. Clinically, COVID-19 presents with very nonspecific symptoms. At the moment, we do not know if VA, using any diagnostic method, can distinguish COVID-19 deaths from other causes. It may be possible, but at this time we think we need further research. SmartVA currently has 34 different adult causes. If VA respondents endorse symptoms such as those that Erin outlined before, we think that SmartVA will likely categorize COVID-19 deaths as pneumonia or other infectious disease deaths. It's possible, however, that SmartVA predicts COVID-19 deaths for other causes such as TB, HIV, and other causes Erin mentioned earlier. Additionally, automated VA only predicts one cause for each death. Unlike physicians who complete a death certificate with an underlying cause of death, immediate cause of death, and contributing cause of death, VA only predicts one cause. For patients with multiple comorbidities, such as COPD, diabetes, and heart failure, it's possible that VA software will attribute COVID-19 deaths to the underlying cause. Next slide, please. With limitations of adding new symptoms and cause in mind, I'd like to emphasize the need for proper validation of COVID-19 verbal autopsy deaths. If we can conduct VAs on certified COVID-19 deaths, we can determine the symptoms that respondents actually report that are associated with COVID-19. We can also determine if VA can distinguish COVID-19 from other VA causes. Finally, we can determine which of the current VA cause categories COVID-19 deaths are being assigned to. Are they being assigned to pneumonia, or are they being assigned to some other cause? Next slide. I'll now talk about some plans we have for SmartVA. SmartVA is unlike most other VA algorithms in that it needs clinically certified deaths with VAs conducted on those deaths in order to determine the relationship between symptoms and causes. The only way we can add a COVID-19 cause category to SmartVA is to collect gold standard COVID-19 cases and conduct VAs on them. And this is something we are currently planning. Alternatively, we could have a rule-based prediction for COVID-19, where if a respondent reports a collection of symptoms such as fever, dry cough, shortness of breath, and mentions a recent sick contact, COVID-19 would be predicted. However, we think this approach is unlikely to be accurate. We are also considering incorporating the local incidence of known COVID-19 deaths into the prediction, which is something SmartVA currently does for HIV and malaria predictions. In the interim, though, we think that monitoring all-cause mortality will provide the best evidence for immediate policy action. Monitoring any changes in cause-specific mortality fractions will also provide useful information for policy. And now, Brian Mukumboy from CDC's National Center for Health Statistics and a technical lead of the Bloomberg Data for Health Initiative's CRVS Improvement Project in Zambia, will present on the application of VA to identify COVID-19 related deaths in Zambia.
Thank you, Riley. I'll present on how Zambia is using verbal autopsy to identify suspected COVID-19 deaths. Next slide, please. As Robert showed, about 46% of deaths in Zambia occur outside the health facility, and these deaths are unlikely to be registered nor certified by a doctor. These deaths are also not likely to be captured in the health information systems. Verbal autopsy is therefore used to ascertain the probable cause of death for these community deaths. And in Zambia, we are currently applying verbal autopsy for brought-in dead cases at hospital mortuaries. Current VA implementation is in 5 districts, which are predominantly urban, in Lusaka, Central, and the Copperbelt provinces, where close to 8,000 verbal autopsy interviews are conducted per year. We use the WHO questionnaire, and InterVA 5 is used for analysis. These VA results are transmitted to the Civil Registration Authority and used purely for statistical purposes, and are also fed into the mortality surveillance system of the Ministry of Health. Next slide, please. As part of the COVID-19 response, the Ministry of Health has set up a rapid mortality surveillance system whose aim is to identify deaths that are associated with COVID, to also do contact tracing and testing of the family members and contacts of the deceased, as well as to monitor the impact of COVID-19 pandemic on mortality. Since a substantial proportion of deaths occur in communities, like I have already shown, it is a challenge for a country like Zambia to effectively identify all COVID-19 related deaths. Thus, using verbal autopsy could be one way to help identify these deaths. Next slide, please. So verbal autopsy has been used to screen and test for possible COVID-related deaths. So how is this done? When a verbal autopsy interview is conducted at the mortuary, which is done daily, results are analyzed, and all acute respiratory infection outputs with the pneumonia, also including those that come out as unspecified infectious diseases, are flagged and reported on a daily basis to the COVID-19 task force. They are also reported to the forensic pathologist. Since all this is done at the mortuary, these flagged cases, for these flagged cases, swabs can be collected from the cavadas by designated staff at the mortuary, and then they could be sent for testing. If postmortem is recommended, then it is done by the medical forensic pathologist. And I've just shown you the graph of why we identified these two outputs, because they are mapping to quite a number of conditions in the ICD that could be related to COVID. Next slide, please. Next slide. This flow chart shows just a process of how a BID case that is brought through the mortuary is flagged and tested for COVID and where the results are sent. The main takeaways from this chart is that after testing or postmortem is done, both COVID-19 confirmed cases or the non-COVID-19 non-confirmed cases are all reported to the rapid mortality surveillance system, where mortality data is compiled for all-cause mortality analysis. To ensure that death registration is conducted and certification is adequately done, MCCD forms, which is a medically certified cause of death forms, are completed, and also for both positive cases and non-positive cases, and they are transmitted to the civil registration authorities, where ICD-10 coding and death registration is done. Next slide, please. So what are some of the issues we have seen in applying verbal autopsy to identify suspected COVID-19 deaths? As we heard from Erin and Riley, from our previous presentations, there is no specific COVID-19 cause from verbal autopsy currently, but we are relying on proxies like probable proxies like acute respiratory infections with pneumonia to flag for these deaths and conduct further testing. However, these proxies might not be capturing all COVID-19 suspected deaths. For instance, just a quick analysis of our Zambia verbal autopsy data, we found that the common symptoms of COVID-19, such as fever, cough, and shortness of breath, were also predominantly present in cases that InterVA reported as HIV and tuberculosis. Thus, for us going forward, we are trying to avoid missing cases that could be possibly related to COVID. So we have come up with a screening questionnaire that would be able to capture most of these cases, and like relying on InterVA outputs. Next slide, please. Like I mentioned, as we wait for the WHO, as we wait for the VA tools to be updated, we have come up with this screening tool. We have identified 7 symptoms, and when a BID case is brought to the mortuary, a questionnaire is conducted, and if any of the any three of the 7 symptoms are ticked yes, then that case is flagged and sent for further testing. That way, we would make sure that we are capturing and conducting more testing on the suspected COVID deaths. It could be ideal that we test and conduct postmortem on all BID cases as they are brought in. But for a country like Zambia, this is not feasible. In conclusion, as knowledge of the epidemiological profile of COVID-19 is rapidly evolving, there is ongoing monitoring to update the current methods used for screening, flagging, and testing of COVID-19 deaths for BIDs. For instance, our current MOH guidelines to test the cavadas should be done within 72 hours of death. But there are questions as to whether the virus can last for more than 10 hours in a dead body, or how the virus would survive in a hot environment. These are questions to which information is still coming out. As we learn more about the virus, our current practices may be evolving based on new knowledge. Next slide, please. And now Fatima Marinho, who is a senior technical advisor in the CRVS improvement project at Vital Strategies, will share how verbal autopsy is being used to identify COVID deaths in Brazil. Fatima, thank you.
Thank you, Brian. Thank you very much. Next slide, please. So I'm presenting verbal autopsy in COVID times, a case study in São Paulo, Brazil, on behalf of the verbal autopsy team in São Paulo. So in São Paulo, the situation is that the governor of the state cancel all conventional autopsies due to pandemic. So the state performs around 30,000 autopsies a year for death at home, clarification of cause of death, and so on. So the state health department implemented verbal autopsy for death at home in the absence of information. So modified PHMRC short questionnaire has been used. This questionnaire was validated in Brazil using autopsies as gold standard. And the questionnaire showed a good performance using a physician certification of the cause of death for verbal autopsy, CVA. Next. So this is the flow established by the government. So you can see first flow is for cases confirmed. So it goes straight to medical certification of the cause of death. So for suspected, it's mandatory collect a swab even for post-mortem exam. So if the cause is unknown, so verbal autopsy is applied. For other cases, it's similar flow. So if you have enough information, medical certification of the cause of the death. If there isn't enough information, verbal autopsy is applied. It's important to say that all death certificates is signed by doctors in all situations, even for verbal autopsy. Next. So next slide is the case study. So I'm presenting here a case study. We have by now around 300 VA applied in 27 municipalities, but I'm presenting 71 cases, analysis of demographic characteristics, analysis of 10 VA questions comparing 3 groups of cause of death: COVID suspected, and pneumonia. Analysis of words in the VA open narrative we are presenting. So these 71 cases were done at the autopsy service in São Paulo city, the same place where VA questionnaire was validated. So infection by SARS-CoV-2 has been confirmed by RT-PCR from nose and throat, and part of the cases also confirmed by minimally invasive autopsy and PCR from tissue samples. Next. So here you can see that 60% of cases were males and age median 59 years. Minimum age was 15, maximum 79. Looks like that COVID cases are younger than the other groups, but this difference is not statistically significant. Next. So here we see the symptoms tested in the 3 groups, okay? So from the bottom to the top, you can see that cough and fever is important symptoms, separating from pneumonia, COVID, suspect and confirmed. Difficulty of breathing was frequent, had higher frequency in all 3 groups. Continued difficulty of breathing separated suspect and confirmed case from pneumonia. Diarrhea and bellyache was more frequent among COVID cases, despite the small frequency. And myalgia was really frequent, 69% of cases. Families reported myalgia. And COVID mention was, 8% of the case was mentioned in the open narrative. And headache didn't show a different, a small frequency. Next. As conclusions, we have more men than women among in the confirmed case group. Fever, cough, and continued breath difficulty were more frequent in COVID confirmed and suspected. On the other hand, breathing difficulty was frequent in all groups, couldn't separate pneumonia from the other 2 groups. What is important in this moment, because pneumonia is a common cause of death. So the higher frequency of myalgia among COVID confirmed could mean that myalgia was an important symptom to identify COVID case, but it needs further analysis. Also, pain in the belly and diarrhea could be considered for further analysis. The mention of COVID-19 in VA open narrative was really important. So it demonstrates the importance of having a good narrative register because it helps a lot the doctor in the understanding the case and the situation and the cause of death. And the results must, of course, be considered with caution since only a few cases were studied, but we have 300 questionnaire, the study is going on. Next, please. So here, as final remarks, COVID-specific questions should be added to VA questionnaire. I believe everyone is discussing about this, and the seminar debate these questions. No, so the point of discussion now is which question to add, because the question will be very important to investigate the cases, not just for VA now, but in the future when we flag like Zambia is doing, flagging the cases, suspect the cases, and in the future you could investigate more using more specific requests. So it's important to check much more questions. So in São Paulo, we are ready to do it. We are adding more specific questions suggested, and we'll test more questions here. So we can compare with the other groups and guarantee that we have a good set of questions that we can now separate COVID cases from other diseases and also help us in the future to reconstruct the cause of death and have real scenarios about this COVID impact itself, and also, of course, as already mentioned, COVID impact in general mortality. Okay, thank you. Obrigada. Next. So let me introduce you, Robert Jacob from WHO, and a specialist and leader of the team of disease classification. Over to you, Robert.
So thank you very much. Next slide, please. So as we have seen, there is a lot of evolving knowledge and different approaches to make verbal autopsy useful in the context of COVID-19. We have some pattern of signs and symptoms that are commonly agreed, but that will lead only to some serious respiratory infections. Other signs and symptoms are to be assessed. And even for the clinical context in high resource environments, there is work going on to assess the sensitivity and specificity of signs, symptoms, and findings. As said by different colleagues now, the COVID-19 in verbal autopsy is likely to appear as serious respiratory infection. Whether in the future we will be able to discriminate it from other respiratory diseases really remains to be seen. Additional certainty comes from the context. As we said, knowledge about the prevalence of COVID in a certain region, contact with COVID cases or travel, and a positive test, of course, are extremely helpful in assessing the cases. Next slide. Now, we also need to see on what we are aiming at in view of the certainties. So we can try to identify cases that are suspected of being COVID positive. Eventually, there has been a test. And of course, what we can definitely do is assess the overall mortality and the excess mortality that will already help in monitoring the epidemic that is currently going on. Verbal autopsy is meant to be used where no doctor sees the dead, and there may be places where even no verbal autopsy is conducted, and we need still to find out a little bit on what is happening in these regions, and that's where rapid mortality surveillance can help to fill the gap. And in order to have some comparability, of course, it's reasonable to have a similar set of questions that look at COVID cases in both systems. And that's what we have been working on to make sure that if data is collected with either system, they can complement each other, at least for the level of saying serious respiratory infection, likely possibly COVID, and the overall mortality. So we can narrow down the days, we can complement the systems each other, and the civil registration system with medical certification, at least for these specific questions. Next slide. So at the short term, we have discussed to add 4 questions specific to COVID-19, permitting to complement this kind of mortality surveillance approach and being in line with this. Exactly as I said earlier, some few clinical and mostly contextual questions. This addendum at the moment is mostly probably used for physician assessment. Also, we have heard that some algorithm like MCCD is already seeking to use this also for the software assessment. And we would recommend that other verbal autopsy systems that are not a WHO questionnaire follow that pattern, so that the surveillance, no matter by what group does it, can complement the information about mortality and mortality in relation to cases that might be COVID. At the long term, of course, we will need some reference data, a diamond or gold standard, or even some standard data set to assess whether we really can identify COVID. We also need to assess whether the symptom pattern is really sensitive and specific. We need to assess whether the questions are well understood, and we need to see whether the questions are also reliably answered. All this then would feed into the ongoing review of the WHO VA questionnaire that aims at making the questionnaire becoming even shorter, so that the questions can feed into the different software algorithms that we heard. And on the other hand, we ask only questions that are useful and understandable. So, and this would mean that there may be an update to the official questionnaires in, as planned in 2 years' time. On the other hand, at a short notice, there will be this addendum with additional instructions, including some instruction how to interpret the pattern of responses received for these specific questions. Thank you very much. And I hand over now to colleague Robert Msvia for the final question and answers.
Thank you very much, Robert Jacob, for the important comments. This brings us to the end of the presentation portion of the webinar. Before we open to the audience for the question and answers, I would like to introduce Lynn Sferaza from the Global Health Advocacy Incubator, who joins the panel for the question and answer sessions. Now moving on to the questions. Here is a question from USA. How can we use this guidance from this call on verbal autopsy quickly in the country? Erin, would you like to respond to that question, please?
Sure, Robert. It's an important question. I think for countries interested in increasing the availability of cause of death information for monitoring the COVID-19 epidemic, the best approaches will depend on where they are starting from, of course, and what resources are available. So first, teams need to take stock of their existing mortality data system and consider what other complementary systems they may be able to leverage. For example, countries with health and demographic surveillance sites are likely to have a wealth of VA expertise that perhaps they can draw on for expansion. Or perhaps there are other public health community-based mobile reporting systems to which death reporting may be added. Also, teams can consider if there are new opportunities through death management structures that may be put into place specifically for COVID-19 that may be able to support death reporting and cause of death collection efforts, like health officials validating deaths in the community or burial teams deployed for community deaths. But of course, teams have to first clarify what their information goals are before identifying the best approach. For teams already using VA, the quickest option is to collect COVID-19 specific information to instruct, by instructing interviewers to capture the key questions in the narrative. And the WHO recommended questions will soon be provided for guidance, and of course, updates for the electronic implementation will follow.
Thank you, Erin. We have a question from Mexico. The question is, what procedure should be followed to apply a test for COVID-19 in rural community? Brian, would you like to answer this question, please?
Yeah, thank you, Robert. For this question, there are not really specific guidelines to test for COVID for rural communities. However, there are general guidelines that WHO has recommended for testing and field implementation for COVID. Specifically in Zambia, testing is done in those areas which are considered as hotspots. So when they see a number of COVID-19 cases increasing, then they could focus their testing in those particular areas following the WHO standards. Thank you.
Thank you, Brian. We also have a question from Philippines. How can you do a gender analysis on COVID-19 related data? I would ask Fatima to respond to this question, please.
Yeah, hi, thank you, Robert. Look, we know that men die more than women in all age groups for all causes of death, almost all causes, but we have much more death among men than women. If for some causes of death, yes, much more men than women. For COVID gender question, I believe there is some gender questions behind this difference because we have observed that more men die by COVID than women in all age groups. But I would consider also that we don't know enough about COVID. And maybe we should understand more to jump for a conclusion about gender difference. But I see that we could use a similar approach to other causes of death that we can see gender difference.
Thank you very much, Fatima. We have a question from Morocco, and maybe this is to you, Robert Jacob. How do we interpret VA analysis results when data collected contains information about COVID-19 deaths?
Yeah, thank you for that question. So the additional questions that focus on trying to find likely COVID-related deaths are going to be published, and the pattern of symptoms will be also published on the WHO website, so it becomes available, giving some guidance what combination makes it more likely and what makes it less likely. Thank you.
Thank you very much. We have another question, and probably this is for Erin. What other tips can you give us to conduct verbal autopsy for suspected COVID-19 deaths while a country is in lockdown and visits to families is not allowed?
Yeah, so I think to the extent that mobile communications can be used, that's the recommended route. But to keep in mind, even where the verbal autopsy can't be completed on schedule, you have two options. You can postpone the VAs to be conducted at a later time when it is safe to access the families, and when the initial death report is provided, trying to collect the more basic level cause of death information to identify suspect COVID deaths, consistent with the guidance that'll be made available in the Rapid Mortality Surveillance Guide.
Thank you very much, Erin. I have a question for Brian. How did Zambia's approach to VA change during the COVID-19 pandemic?
Yeah, it has changed. Like I mentioned, our verbal autopsy implementation was specifically to have information on the cause of death for the community deaths. So with the verbal autopsy, with the COVID-19 coming in, and especially in the communities where we're unlikely to get the cause of death information, verbal autopsy has been integrated as a screening process to identify these cases and conduct further testing. I believe with all the information that we are capturing, it will be very helpful to provide this information to the verbal autopsy reference group to really analyze the data and understand more about COVID. Thank you.
Thank you, Brian. We have a question from Kenya, and probably this is best addressed to Robert Jacob. What is the timeline to finalize the guidelines and adjustments of tools for analysis?
So the guideline for tools for analysis, we are working on this so that we can have a kind of real-time cause of death reporting to WHO. Work is ongoing on this, and the same for the publication of the addendum to the verbal autopsy questionnaire and the interpretation. This is something we're talking about this or next week. Thank you.
Thank you, Robert. We have a question also, and this will be open to anyone in the panelists. If we are already conducting verbal autopsies on a small scale in our country, should we try to expand? Erin, do you want to attempt that question?
Sure. I think if certainly the information is valuable, if there are the resources to expand without compromising the ability to continue the flow of information on all deaths, I think it's worth considering for the value of the information. But that, of course, depends on the availability of the additional resources to support expansion. Verbal autopsy in new areas requires extensive training and support for the data collection platforms and linkage for data management systems. But there certainly is value if those resources can be secured.
Thank you, Erin. Here's a question for Robert Jacob. Will the WHO or any other organizations be looking at VA COVID results to look at international patterns?
I'm not sure what the meaning of the question would be. I think if it's about international patterns, that's what was discussed earlier, that we're in the learning phase of a pattern of disease, and will certainly make adjustments if necessary. Also, as said earlier, in verbal autopsy, identification of specifically COVID may not be easy. Thank you.
Thank you, Robert. We also have a question, and I think this was slightly addressed in the presentation, but maybe Erin, it was in your presentation. How can we stay updated about the changes in questionnaires or guidelines that you are making?
Sure, I think probably the best way is to access the WHO VA Reference Group website, which is available through the Swiss TPH broader website. The link will be available in the slides when they're distributed. There's a mailing list there that you can sign on to. And of course, this website has the links to the WHO website for the official tools when the questions are added and the electronic version of the questionnaire is updated. Of course, that'll be posted on the WHO Verbal Autopsy website. But in terms of some of the other guidance and experience gained, the community will be working through there.
Okay, thank you, Erin. There's a question on how much time after death is a postmortem swab still useful? Maybe Fatima, do you want to respond to this question?
Yes, it's a good question, no? Because everyone want to know just, so look, discussing with virologists and PCR specialized professionals, they suggested 10 hours maximum to have enough RNA, virus RNA, to test for PCR. But pathologists says that it could have 24 hours because they have been testing it and looks like that 24 hours you can find virus to test PCR. but it's not a final answer, okay? We are just learning about it.
Thank you, Fatima. There's a question from Nepal. How can VA data incorporate in CRVS? Riley, do you want to try to respond to this one?
Yeah, thanks, Robert. I think that's a difficult question to answer because I think there's a lot of research that still needs to be done there about how we can take verbal autopsies that are very much different from medically certified causes of death and then incorporate them into CRVS systems. It's something that we're working on, but I don't think I have a great answer for you at the moment. Maybe someone else has a better answer than I do, though.
Thanks, Riley. Anyone in the team that would like to add something?
Yes, I would like to add because it's important in this moment for COVID, you have verbal autopsy certified by doctor, if it's possible, of course. Because if it is certified by doctor, you can have legal proposals and add it to your vital statistical systems. If you don't have enough doctors, so you could have applied verbal autopsy in the future or rapid mortality survey to flag the case and investigate in the future.
Thank you very much, Fatima. It seems like we've reached at the time when we need to hand over this back to Carlos. That before we do that, we have received a lot of questions and we will try our best to respond to all the questions that we received by email. And so in the next day or so, you will receive all your questions, the answers to your questions. So at this point, we have come to the end of the Q&A session. Thank you all very much for your participation in this webinar. I will now hand over to Carlos.
Thank you, Robert. And thank you to our presenters, and thank you all for joining us. Our next session will be at this time, Wednesday, May 13th at 8 a.m. Eastern Standard Time. The topic is measuring excess mortality due to COVID-19. When this session ends, you will be prompted to take a short survey, which should only take a few minutes to complete. Please note that this session has been recorded. We will circulate this recording and the slides to the group. We will also try to answer most of the unanswered questions you submitted in a subsequent email or session. Thank you again for your participation, and we look forward to hosting many of you during the session next week. Please keep an eye out for an email with more information on that session. Thank you.